Good day. My name is Dr. Jay Snow. I am a hospitalist with the Hospitalist Service at Children's Hospital Medical Center here in Omaha, Nebraska. Today we'll be discussing pharyngitis. I have no financial or material conflicts to disclose. My objectives for today's discussion are to describe the historical and physical findings that help differentiate Group A streptococcal disease from viral pharyngitis, and to discuss the antibiotic choices and the rationale for those choices for treating Group A strep pharyngitis. Going back to our training, we remember the Group A strep, or strep pyogenes, is a gram-positive cocci in chains. The image to the right-hand side demonstrates light microscopy with H&E gram staining of the organisms, showing small, round, purple organisms tied together as if they were beads on a chain. The larger picture on the left is an electron microscopy technique, clearly demonstrating the round cocci shape and the bead-like structure that they arrange themselves in. Strep pyogenes exhibits beta hemolysis, which is complete hemolysis on a sheep blood agar plate. This is a picture courtesy of Becky Buxton at the University of Utah, where she has swabbed alpha strep in the upper left, gamma strep in the lower portion, and beta hemolytic strep in the right upper quadrant. As you can see by the white around the beta hemolytic strep, the Group A strep has completely hemolyzed the sheep's blood on the plate. Group A strep is classified in the Lancefield classification system based on the C carbohydrate antigen of the cell wall. There are more than 120 distinct serotypes and genotypes of Group A strep identified worldwide. Despite this abundant number, humans are the only known reservoir for Group A strep. Group A strep is spread by direct contact with the respiratory secretions from an infectious individual. There have been no vector spreads, as it has not been found in other animals, and it has not been spread by fomite, meaning infected respiratory secretions on a surface being passed to another individual. Once a person is exposed directly to the respiratory secretions of an infected individual, the incubation period is typically 2 to 5 days. Most commonly, strep pyogenes infects those 5 to 15 years of age. It is rare under 3 years of age. Its incidence diminishes rapidly as we move into our young adulthood. Its peak incidence throughout our lifetime is around 7 to 8 years of age. In the United States, the peak infection time occurs from late autumn through winter into early spring. This is thought to be largely due to the school year calendar that most children in that age group are following and the close proximity that they are in to each other. Group A strep pharyngitis classically presents with a sudden onset of a sore throat. This is frequently accompanied by pain or discomfort with swallowing, known as odynophagia, and fever. Additionally, children may have headache, abdominal pain, nausea, or vomiting. In fact, there are cases of children being taken to the operating room for appendicitis, and after a normal operative procedure with a normal appendix, being diagnosed with Group A strep pharyngitis. Physical exam findings will frequently include pharyngeal and tonsillar erythema. There is frequently tonsillar enlargement or hypertrophy, and the tonsils may or may not have any exudate present on them. There is often anterior cervical adenopathy, and when present, that adenopathy is frequently tender. Careful exam may reveal petechiae on the palate and often will demonstrate a strawberry tongue. If a rash is present at the same time, it is usually a scarlatiniform rash, which is confluent, erythematous, and sandpaper-like. This is known in conjunction with Group A strep as scarlet fever. It results from one or more exotoxins being produced by the Group A strep. Historically, this has been known as second disease. First disease was rubella or measles, rubeola or measles. Third disease was rubella or German measles. Fourth disease was Philotow-Dukes, which perhaps was a reference to staph-scalded skin syndrome. Fifth disease is erythema infectiosum, caused by parvovirus B19. And sixth disease is exanthum subidum or roseola infantatum, which is HHV6 and HHV7. This is a picture taken from the Red Book demonstrating a child with scarlet fever. The scarlatiniform rash is clearly visible on his torso as well as his back. Additionally, he has his tongue protruding, demonstrating the strawberry nature of it. The clinical features of pharyngitis cannot be used to reliably discriminate between viral etiologies and group A strep as the etiologic agent. Group A strep causes only 20 to 30% of the episodes of pharyngitis in children. That leaves 2/3 of the cases being caused by a viral etiology. Epidemiologic features that would suggest a viral etiology would include the presence of cough or hoarseness, rhinorrhea, or oral ulcerations. Because it is difficult to differentiate between the two conditions, rapid antigen detection testing should be performed in all children 3 years of age and older, and in selected children under 3 years of age. For example, children with a community outbreak or a multiple family member outbreak. If the rapid antigen detection testing is negative, a backup culture should be performed. However, if it is positive, a backup culture is not needed. This is due to the high specificity of the rapid detection systems that are available today. Historically in medicine, we've always asked how to treat something. There is a movement, a growing movement, that suggests perhaps we should ask, should we treat? This is perhaps best represented nowadays by the discussions revolving around bronchiolitis and the lack of efficacy of any interventional treatment. Group A strep, when untreated, is usually a self-limited disease. However, if it is untreated, complications are significantly higher than in treated individuals. The Red Book clearly states that the goal of therapy is to reduce acute morbidity, to reduce the complications, and to reduce transmission to close contacts. It is not to cure the individual of their pharyngitis. Penicillin was the original and remains the antibiotic of choice for this disease process. Amoxicillin is often used as a substitute. There has never been a clinical isolate of group A strep that is resistant to penicillin. In an individual who has had a non-anaphylactic allergy to penicillin, a narrow-spectrum cephalosporin, such as cephalexin, is the preferred therapy. And those children who have had an anaphylactic reaction to penicillin or have a type 1 hypersensitivity to penicillin, clindamycin is indicated for them. Macrolide therapy may be an option. However, erythromycin is poorly tolerated by many children due to its GI distress, and group A strep resistance is estimated to be 5 to 10% across the country, with pockets of resistance as high as 20%. The resistance rate in the Omaha metro area is not known, as the local labs do not regularly test for group A strep resistance to macrolides because of its universal sensitivity to penicillin. The treatment of group A strep pharyngitis remains, the gold standard remains penicillin. This can be oral penicillin in the form of penicillin V, which is dosed based on a weight of under 27 or over 27 kilograms. In a child under 27 kilograms, the dose would be 400,000 units or 250 milligrams, 2 to 3 times daily for 10 full days, and double that dose for heavier children twice daily for 10 full days. The dosing regimens that we learned in school of 10 days all stem from the original therapy, demonstrating that the complications of group A strep pharyngitis are significantly diminished if an individual undergoes a full 10-day course. And less than a 10-day course, they still have a high incidence of post-infectious complications. We will discuss more of those later. An option for those who desire would be penicillin as a single dose using penicillin G benzathine. Penicillin G benzathine injection ensures compliance as it is given in the office and no further dosing is necessary. However, it is painful. There are places and protocols that utilize a mixture of penicillin G benzathine and penicillin G procaine in a 3-to-1 ratio. This is less painful for the child, but there is limited data in most children and very little data at all in older children and young adults as to its efficacy. There is no evidence that it does not work, however. Because of the issues around the compliance with oral penicillin and the pain with intramuscular penicillin, amoxicillin is the most frequently prescribed medication for the treatment of group A strep pharyngitis. Amoxicillin is good tasting, and its dosing regimen of 50 milligrams per kilo once daily improves compliance with 10 doses over a 10-day period. As mentioned earlier, cephalexin would be indicated in a child with a non-anaphylactic reaction to penicillin in a dose of 20 milligrams per kilo per dose twice daily for 10 full days. In those who have had an anaphylactic reaction to penicillin or have a type 1 hypersensitivity to penicillin, clindamycin is the agent of choice at a dose of 10 milligrams per kilo per dose to a maximum dose of 900 milligrams, again for 10 full days. The complications of group A strep pharyngitis could be suppurative or non-suppurative. Suppurative complications would arise from the direct spread of the organism. Minor complications might include otitis media or sinusitis. More significant complications would include cervical lymphadenitis, retropharyngeal or peritonsillar abscesses, or mastoiditis. Non-suppurative complications occur after the resolution of the disease and affect sites remote to the pharynx. These would include acute rheumatic fever and post-streptococcal glomerulonephritis. Appropriate treatment with antibiotics will reduce all of these complications except post-streptococcal glomerulonephritis. Acute rheumatic fever still relies on the Jones criteria for the diagnosis. The Jones criteria requires chorea, Sydenham's chorea, or 2 major criteria, or 1 major and 2 minor criteria with supporting evidence such as confirmed group A strep pharyngitis by rapid antigen detection or culture. Post-streptococcal glomerulonephritis ranges in presentation from an asymptomatic individual to a full-blown nephritis. It is most common in developing regions of the world. This is thought to be due to a higher incidence of nephrogenic strains of the group A strep, as well as lack of access to appropriate antibiotic therapy in the course of the illness, allowing for a much wider spread during outbreaks. The estimated incidence in the United States is 0.3 per 100,000 children. However, that incidence is based on biopsy registries, which likely make the estimate extremely low, counting only the severe cases. Regardless of the severity of the nephritis, the course is generally benign in most children. Some individuals will be carriers of group A strep without active disease. A carrier is an individual who has a positive throat culture or rapid antigen detection test but does not have clinical symptoms. Asymptomatic carriers of group A strep do not require treatment. Carriers are much less likely to transmit group A strep to others and are unlikely to develop complications from the group A strep. Determination of carriage, however, is very difficult. The Red Book suggests that carriage should be suspected when a patient has repeated and frequent episodes of acute pharyngitis with positive testing. The Red Book suggests that we ask ourselves 4 questions to determine whether an individual is a carrier or whether the group A strep positive testing reflects actual disease. First, are the clinical findings more suggestive of group A strep or a viral cause? Does the child present, for example, with hoarseness of voice and rhinorrhea, which would suggest a viral cause even in the face of a rapid positive test? Is the local epidemiologic pattern more consistent with group A strep or a viral cause? Our epidemiologic testing in this region is not robust enough for us to reliably determine whether there is a viral outbreak or a group A strep outbreak, and probably does not make this recommendation very helpful. Does the pharyngitis respond immediately to antibiotic therapy? Group A strep pharyngitis should respond within a 36-hour period from the initiation of the antibiotics. If the child continues to have clinical symptoms beyond 48 hours, it would suggest a viral etiology as opposed to a true group A strep etiology. And finally, does the child have positive testing between episodes? This would be the easiest way to identify these children. However, it would require an additional visit when the child is not ill to the physician's office, and would require a rapid strep test and or culture be performed, which the child is unlikely to be happy about. Testing for serologic response, anti-streptolysin O or ASO titers, is not indicated to determine carriage state. Children's Physicians has developed a pathway that will be going into use soon. It is expected and hoped that this pathway will be available to clinicians throughout the area after further review of the pathway. If you ever have questions and need the help of a specialist at Children's Hospital and Medical Center, please call our Physicians Priority Line at 855-850-KIDS 5437. There are sources listed at the end of the presentation. Most pertinent would be the IDSA guidelines on group A strep pharyngitis, which were updated in 2012.